been something that we've done, and whenever we get our things back from everybody who's attended that tells us what they like, this is one of the programs that they've really liked more than a lot of other ones, and so we're always happy to showcase our APPs. Like John was saying, we have 26 presently employed, 4 more coming. I remember way back when we had Roger and a few others, and that was pretty much about it. And but we've really grown, and I can see that it's going to grow more. But they provide a tremendous service, have a vast amount of knowledge, and we're really happy to showcase what they're going to share with us today. So on the far left here, this is Evelyn. Evelyn's been with us for a long time. She got her RN degree in Binghamton, New York, and a BSN in nursing from Binghamton University. She came to Rapid City in 1990, so she's been here almost as long as I am. She worked in cath lab and various areas, and then got a degree at SDSU, and then since then, as a nurse practitioner, she's almost worked in exclusively with Dr. Teixeira and with electrophysiology, and so she's been doing that for 23 years, so she's been here for quite a while. And then in the middle, we have Jessie Albers. So she worked as a nuclear medicine tech here at the hospital for quite a long time, and then went and got her physician assistant degree at Eastern Virginia Medical School in Virginia. She had worked in vascular surgery for a period of time, and then came back home to Monument Health, and now she's working in CT surgery. And on the far right, Jason. Jason's a PA. He was a graduate of Touro University in California at the PA-MPH program. He's currently the lead APP for the cardiothoracic surgical group at Monument Health. He's been here for 3 years. Unfortunately, he's going to be leaving in November, but hopefully he's been able to find and help us recruit good people to come to kind of take his place as he leaves. So I'll leave that with them, and we'll get Evelyn started first.
I don't know if mine is, I guess mine is working, so we can. Okay. Oops. Do we need to shut this off? Mine is working now, so we can. Okay. Good afternoon. I hope everybody's awake after lunch. And one of the comments that came out of the cardiovascular symposium last year was, what do you learn from a pacemaker interrogation? So that's my talk today, and so I thought it would be a little more interesting if I did what we find from most device interrogations, and that includes loop recorders, pacemakers, and defibrillators. This doesn't seem to be advancing. Oh, Cece told me to use this. Oh, okay. So first of all, we figure out what type of a device it is, and whether it's a pacemaker, defibrillator, what brand it is. We implant primarily Boston Scientific devices, but we have a fair amount of Medtronics and a few Biotronic and St. Jude devices. All our new micro pacemakers, those are Medtronic. And I encourage you to go out to the vendor booths. Both Boston Scientific and Medtronic have booths set up with their devices, and you'll see the tiny loop recorders that are implanted under the skin in the upper chest, as well as the micro pacemaker that's implanted, goes in on a catheter through the femoral vein up to the, and is positioned in the right ventricle. So that's some of the newest technique or devices that are implanted. And so pacing modes, that's can get pretty complicated, but essentially they're single chamber, dual chamber, or biventricular devices, and they can pace just the bottom chamber or both the atrium and the ventricle, and the CRT devices where you want cardiac resynchronization to help with heart failure and increase the ejection fraction and pump ability of the heart. Those are called CRTPs or CRTDs for defibrillator. And then you see they can be DDDR, so the R stands for rate response, and that is a sensor that blends the minute ventilation or breathing along with an activity sensor. So it blends those two sensors together and comes up with a algorithmic heart rate. So, on the loop recorders, this is what the kind of a printout you get, and it records. It can record if the patient has symptoms. They can activate it. It's also programmed for certain parameters. So if there's a tachy episode that lasts, this is set up to, if it lasts 158 beats per minute for more than 16 beats, then it records it and marks it. And that if there are pauses greater than 3 seconds, or Brady events where the heart rate is less than 30 for 12 beats. And those can be adjusted. Like if patient's having symptoms that aren't being recorded, you can like decrease the trigger rate from like 158 to 140, or the pauses, you probably don't want to change that, but Brady events, if they're having symptomatic bradycardia, with rates in the 40s, you're not going to see it with the setting program to less than 30, unless they start having pauses or more significant bradycardia. So there's also atrial tach or atrial fibrillation episodes, and it'll give you the percentage of atrial fibrillation the patient has, and that'll be an indicator, you know, whether or not they're going to need some antiarrhythmic medication or possibly an ablation. And it gives you a presenting rhythm strip on the bottom there. So when we get the report, if there are episodes that have been recorded or tracked, then that will also print out so you can look at them and figure out what it is. So our first case is RO. He's a 76-year-old male with a history of 2 CVAs in the past, known atrial fibrillation on anticoagulation. Unfortunately, when seen in the office, he was only taking his Eliquis once a day. And I've seen that with a few patients that to save money, or they were concerned with bleeding, that they decided to cut it back to one per day. Unfortunately, he went on to have another stroke. His CHADS-VASc score is 7, so he is high risk. And past medical history significant for coronary disease, diabetes, hypertension, hyperlipidemia, 20-pack-year history of smoking. And he'd had a prior loop recorder implanted 6 years prior, and that had reached end of life, so it was no longer functional. And he still had it in. He elected not to have it taken out. So he continued to have TIA-like symptoms and was seen by neurology. They requested that the loop recorder be replaced. So he came in, they took the old one out, implanted a new one, and that was done in January of 2023. So the first indication that there was something other going on was in September, when we finally saw multiple pauses, the longest 7.9 seconds, followed by a 5.8 second pause. So the rhythm before and after the pauses was severe sinus bradycardia. He also had a little bit of atrial fibrillation. And so on the top of this, you can see what the events that were recorded that were significant. And then this is a tracing where they, you see the sinus brady at the top, and it's pretty slow. And then a 7.9 second pause and another 5.8 second pause on the bottom, and then the sinus bradycardia. So he was contacted and instructed to come into the hospital right away. He was implanted with a dual chamber pacemaker, and the ILR was explanted, the loop recorder. And when seen in follow-up, he was doing well, and so he was enrolled in the pacemaker clinic for ongoing monitoring and surveillance of his pacemaker. So the next clinical scenario is deals with a patient with a pacemaker. So she'd had her initial pacemaker implanted in 2013. And she had a history of hypertension, hyperlipidemia. She'd had a prior CVA, but no residual effect, really. She was a very spry 86-year-old, very active, volunteering. And so she'd been implanted with a dual chamber pacemaker back in 2013. Had a left subclavian implant, and oops, go back there. So you can see left subclavian implant, the leads are through the subclavian vein on the left, and one position in the right upper chamber, one in the right lower chamber, the right ventricle. So these new micro pacemakers I mentioned before, they're implanted on, they are on a catheter that goes through the femoral vein, up through the vena cava and into the right atrium, right ventricle. And so it's, once they get it in the right position in the right ventricle, then they deploy the little grabbers. And you can see those when you go out to the booths. And it's positioned there. And they detach the catheter, that comes out, and the little pacemaker stays in there. So this is a typical printout from a pacemaker interrogation, and this is the lady that is at explant time. Some of them say ERT, elective replacement time. Hers says explant time. So that little gas gauge on the right side is it would be all the way to the right at the 3 o'clock position when it's new, and then as the battery ages, there's a little dial like a clock, and it reaches a spot called 1 year remaining, and then explant. So when it hits 1 year remaining, they start doing more frequent checks to track the battery life closer. So they catch it when it hits elective replacement. So hers reached elective replacement on May 8th, 2023, and was replaced. You can see the magnet rate on her pacemaker was down to 85. Brand new ones, the magnet rate will be 100, and that means when you put a donut magnet on, it'll switch to fixed pacing and it'll pace at 100 beats a minute. And as the battery ages, that pacing rate will come down, magnet rate. And then you also see on the bottom the intrinsic amplitude of the P wave and the R wave, and also the pacing thresholds, what they've gotten when they've tested. A threshold is the least amount of electrical energy coming out of the device that's going to capture or pace the heart. So, and then it also measures lead impedance, which can be an indicator if there's a fracture or a break in the wire. The impedances will be lower than they're supposed to be or higher. And this is more information that's printed out with the device interrogations. It'll track VT episodes or SVT episodes, non-sustained episodes. It tells us how much the patient is paced in the atrium. On this one, it's 80%. That's device total, and it'll break it down from the last or from the previous device check to the current one. So she's 82% paced in the right atrium and minimally in the ventricle, less than 1%. Lifetime total is 2%. And then it also shows you a PVC counter, which is very handy if you have a patient who is having a lot of ectopy or palpitations. You can assess their PVC burden and then decide if something needs to be done about that. So this is, we see other arrhythmias on the device interrogations. This is a little run of non-sustained VT. The lead on the top is the atrial lead. The second line down is the ventricular lead. So you can see there's a run of 7 beats of non-sustained VT there. So that might be, something you want to look into. Has the patient had a recent ischemic evaluation, or are the electrolytes out of balance, and do you need to bump up their beta blocker, or check an echo for the ejection fraction to make sure that hasn't gone down. This is what atrial fibrillation looks like on the device checks. You can see again the top line is the atrial lead, and the second line is the ventricular lead. So the atrial lead is going real fast, and that's atrial fibrillation. There's more A's than V's. And the ventricle is tracking fairly fast also. So depending on the burden or how long these last, you're probably going to need to do something with that. And then sometimes you see other interesting rhythms on the device interrogations. So this is an SVT, and it's most likely a common, well, not common, but AVNRT, AV nodal reentrant tachycardia. So you can see the A's and the V's are occurring almost simultaneously, which is typical for AVNRT. So depending on the amount of this and the symptoms of the patient, they might be referred for ablation, considered for ablation. So this was actually a female patient in the clinic, and she was quite symptomatic with this racing, so she went on to have an ablation and get rid of that. So this is what a mode switch looks like when the patient goes into atrial fibrillation. You can see on the upper line is the atrial beat, and then the ventricle follows. And the first few beats are normal pacing. Then it goes into atrial fibrillation and rapid ventricular response. And so the device will switch modes so that it won't try to pace through the atrial fibrillation. It'll only pace in the bottom chamber if it needs to. And then when the ATR episode ends, hopefully it ends, then it goes back to pacing dual chamber again. So this lady, patient came back into the clinic early. She had her pacemaker placed. She was unable to carry out normal activity due to AFib with her RVR. She just couldn't function. Anytime she tried to do anything, she felt pounding and racing and severe shortness of breath and exercise intolerance. And she'd had to give up her volunteer job. So again, she's 86 years old. So she had a bunch of mode switching episodes on her pacemaker, AFib, RVR. So she at 86, you're probably not going to want to do an AFib ablation on her. So we ended up putting her on low-dose amiodarone. We didn't really have any room to increase her beta blocker therapy any further because of hypotension. And so we'll continue to monitor. At some point, if we're not able to control her atrial fib adequately, and she still has the problem with it going fast, then she might be considered for an AV nodal ablation, which is a much less complicated ablation procedure. So then we go on to defibrillators, and essentially when you interrogate a defibrillator, you're seeing the same kind of information in terms of what their program settings are for pacing, what their thresholds are, what their lead impedances are, and it'll also tell us how it's programmed for the defibrillation. So KB is a 68-year-old male with a history of coronary artery disease, prior MIs, bypass surgery. He had a dual chamber defibrillator placed for ventricular tachycardia a year or two earlier, and then he had a high percentage of RV pacing, so he ended up with an upgrade to biventricular ICD, and his ejection fraction previously with the RV pacing had been in the teens and improved up to 28% with BiV pacing. However, he had multiple ICD therapies, both anti-tachycardia pacing, where the defibrillator will try to pace faster than the VT and terminate it. And it'll do that. Usually it's programmed for four ATP episodes, but then you can adjust those also. So he started having more ATPs and also some shock therapy from his defibrillator. And when you interrogate the device, it will print out on the top. So this one was fairly benign, but on this you can see he's got the 3 leads. So you see the RA lead, the RV lead, and the LV lead. Their thresholds, lead impedances, and intrinsic amplitudes, P waves, R waves. And he's programmed DDD, so he's pacing both the upper and lower chambers of the heart, and it's BiV, so he's pacing both lower chambers of the heart. And his rate's set for 60 beats per minute and tracks up to 130 beats per minute. Then you also see the VT information, what his zones are programmed for. So his VT zone is set for 170 beats per minute, but that was programmed off for any therapies. His VF zone is set for 200 beats per minute, and it'll deliver 8 shocks, 41 joule shocks if needed. So this is non-sustained VT. You can see the atrial channel, the rate's fairly well controlled, and then the V's are going quite fast. So that's non-sustained VT. It did terminate on its own. There's on this one, it's sensed VT and delivered this is a burst of ATP where the defibrillator paces 10 beats at a fast rate to terminate the VT. Unfortunately, he continued to have more therapies, and one of the things I like to look at is the arrhythmia logbook, which you see a part of it on the top there. So he'd had some non-sustained VT episodes, and it's apparently programmed so that after 14 seconds, then it would start delivering ATP, because you'll see no therapy programmed or no therapy delivered. When it gets up to 15 seconds, 16 seconds, then you'll see the ATP on this, the way this is set up. And then this is his arrhythmia logbook. So you can see in March he had a few episodes and terminated with ATP. And then in April he started having more and more. VT episodes, VF episodes, and got more ATP. And you see some here on like April 5th, apparently April 5th was a bad day, where he had ATPs and then shock therapy. 41 joule shocks delivered. So this is sort of accelerating or crescendo type symptoms. We call this sometimes VT storm, where they just are continuously going in and out of VT, terminate it, and then he goes right back into it. So this is ventricular tachycardia, and you can see on the bottom here the device charges, detects it, and charges, and then it'll always take a second look, and sometimes it'll deliver a burst of ATP to see if that would terminate it. But he'd already gotten ATP, so this charged it, and then he received a 41 joule shock. And it did terminate the arrhythmia. However, he went right back into it and received another shock. So he went on to have a VT ablation. And on mapping in the EP lab, he was found to have 5 different VTs. So they were successfully ablated by one of our very talented EP docs. And he did well and was discharged. So, a shout out to Dr. Levine and Dr. Barbera. Their expertise is something that, you know, they're cutting edge. They do amazing work. And that's all I have. Do you want this?
So, everybody still awake from the lunch that we had? It was pretty good, wasn't it? Let's talk about the fun and exciting aneurysms. Maybe, possibly. There we go. Okay, so let's start off with defining them. We're going to talk about arterial aneurysms today. As you can see, the first one shows healthy vessels. And our true aneurysms, there's basically 2 forms. You can either do saccular, which is bulging out one side, or the falciform, which are more common, where the whole vessel bulges. And the definition of that is if it's 1.5 times greater than its actual size. You can also get false or pseudoaneurysms. That happens when you have a dissection in between the intima and the media, or even with the adventitia. And what happens is that increased pressure will actually cause the vessel one or two of the walls to bulge, not all 3. Generally happens whenever you have some kind of intravascular access. Where can you get them? Pick an artery. You can get one. Most commonly in the cerebral circulation, it's going to be the proximal anterior side. In the body, your ascending and your abdominal aorta have the highest risk. And peripherally, it's going to be in your popliteal. Why do we really care? About 5% of the population has an aneurysm. However, only about 25% of them will actually know they have one when they arrive at the hospital with a rupture. When they rupture, well, bad things can happen. If you're home in your bed, you won't wake up. With cerebral, about 50% will survive. However, about 50% will have some neurologic morbidity with seizures or stroke-like symptoms. They have, whoopsie, wrong button. They have a risk of re-rupture in about 1 or 2 weeks, You have vasospasm, cause ischemic stroke on top of having your hemorrhagic stroke, seizures, things like that. With your aortic aneurysms, if you make it into the hospital, you still have a 48% morbidity rate. So it's still very risky to not get in. And then with popliteal, you're at high risk for amputation. About 46% show up because they have either occluded their aneurysm or thrown a clot further downstream, requiring at least BKA. What risks do we need to watch out for then? So genetic conditions like Marfan's, any of your connective tissues, Ehlers, Danlos, anything that makes those vessels weak obviously puts us at increased risk. Your primary risks are going to be uncontrolled blood pressure, smoking, and of course drug use. Those amphetamines and cocaine, very high risk because they increase your blood pressure dramatically. With cerebral, I found it interesting, polycystic kidney disease and coarctation of the aorta are both risks. So it is very important to get very thorough histories on these folks to see what their family history is and their history as children. Symptomatically to look for, cerebral is going to have your most symptoms because there's not much room for things to grow up there. So you're going to have more of the weakness of pupil dilation, paralysis on the side of the face, things of that nature. With your aortic, it's going to be from some kind of displacement. You're going to get some hoarseness or dysphagia as the thoracic aorta is pushing on the esophagus. You can get some back pain, chest pain, as it grows and pushes on nerve roots. And the biggest thing with especially thoracic aorta is you can get some tearing pain because those like to dissect. So anybody who comes in saying they have tearing chest pain or back pain, this should be on your list of things to look for. And then, like I said, with popliteal, also having CLI. Not all will rupture. There's several things to consider, like the size, the location, things of that nature, which we'll go into a little bit later. But if they do, you can have a seance and ask all these folks. Yeah, not good things can happen. So, all right, so should we screen the entire population? Well, the U.S. Preventative Task Force and Medicare got together, and they decided that only men from 65 to 75 who have ever smoked need to have a screening duplex for AAA. No real guidelines on any other aneurysms. Cerebral, they recommend go ahead if they have a relative who's had a ruptured or subarachnoid hemorrhage, or if they have that polycystic kidney disease or coarctation of the aorta. The biggest screening you can do is the physical exam, and obviously discussing with your patient if they have any risk factors. Now, with our patients being a little fluffier, it's a little hard to actually get that abdominal aorta checked out with palpation, but you can listen for bruit, you can palpate for popliteal, things of that nature. So you get concerned, you send your patient off. Oh boy, they have an aneurysm. What do you do now? Well, if you don't know, send them off. If they've got anything below the brain, send them to the vascular side of things. If they have a brain aneurysm, the neurovascular team is fabulous, and we'll get them in. If they're in the outskirts, you want to monitor them yourself, that's just fine. We tend to, the first thing you do after you find an aneurysm is the 6-month re-imaging. Very important, because one of the guidelines is if it grows quickly, it needs to be repaired sooner. Think of a water balloon. Whenever you're blowing it up as a kid, you blow it up real fast, it blows real quick. You do it nice and slow, it can get pretty darn big before it'll actually rupture. Same thing with our aneurysms. So it's very important for us to see not only that they have one, but how much is it actually going to grow, or has it been growing? They do grow, about 3 millimeters a year is average. So, and then the rest is just monitoring guidelines that over the years, then with the sizes and whatnot. But we do not surgically treat everybody. The first thing that you guys can help us with is blood pressure control. Smoking, as we've repeated numerous times, smoking is bad. So it's actually found to be, if you have a 5-pack year history, you have a 35% increase in the growth rate of your aneurysms. So very important once found that they stop smoking. And of course, drug cessation, getting them off that meth that they love around here. And then, of course, healthy exercise. These folks can exercise. Please tell them that they can exercise, because that healthy lifestyle will help keep everything nice. So here's when we treat our asymptomatics. Like I said, size is a big factor. For our abdominals, it's 5.4 centimeters, and for our AAAs. For cerebral, 7 millimeters, they tend to want to treat unless it's somebody who's younger or they have a daughter sac, a little sac on a sac. That's very high risk of rupture. Popliteals, we tend to be concerned if they're over 2 centimeters. And then things like it affecting the aortic valve. If you have an ascending aneurysm and they have a bicuspid valve, they're more likely to have regurgitation and can induce heart failure. So we like to treat those more quickly. So repair. So with these, there's obviously the old school way of open repair, but now we have the endovascular way, which is gaining steam, obviously. So we do much more endovascularly than surgically. Things that we take into consideration, obviously, is their comorbidities. If they have extreme CAD or COPD, chronic kidney disease, not really a good idea to make a huge incision to open these guys up to evacuate or to repair an aneurysm. So we like to try and do things endovascularly for those folks. But there are some limitations to that as well with each type of aneurysm, which we will get to here. So let's start at the top. Here's some pretty little berry aneurysms. So here's our repair. I'll just kind of go here. So the way they open repair these is with B. They put a clip on it. Now locally here, the neurosurgeons tend to only do this if they have a large subarachnoid hemorrhage that needs to be evacuated. Otherwise, they tend to not do that here. They will send them to Sioux Falls if it is a large aneurysm. The other things that they're going to consider is the size of the neck. This here, as you can see from this picture to this, the neck is very wide in this one. So it takes more than just these coils. These are coils they can put in endovascularly to try and occlude that aneurysm. If it is ruptured, they kind of like to do more of the stent graft to occlude the whole thing. And they can do the coils as well as stent graft, but then they can do a follow-up angiogram to make sure it is completely occluded. The problem with the coiling is it's got a recurrence that's about 24%, whereas open repair, it's a lot less. But they can go back in and they can do more coiling if they need to. So overall, the 1-year morbidity rate is a lot better, 6.4% versus, I believe, 9.8% there. The other things they have to worry about is inability to treat because at the bifurcation, or if it's at terminus, the basilar arteries, they can't really do that. So there's different things they take into consideration for if they have to send them to Sioux Falls to get repaired. All right. These are some nice aortic aneurysms. We got saccular aneurysm and falciform there. So for our body repairs, this is a nice graph that shows kind of the difference between who we pick for what. Younger patients, obviously, we can do open repair a lot easier because obviously they'll handle it better. And as for longevity, we're still under the impression that long-term open repair is better. There's less monitoring that needs to be done. If they're sick, we can do a bunch of different endovascular repairs, as you can see here along the arch and whatnot. If it is an in-depth aortic arch aneurysm up here, they can actually do a dual procedure. They can endovascularly put a graft in the arch and then do an open repair of the for the arch vessels. Outcomes-wise, obviously, if you open them up, you're going to have some risks. You're going to have risk of needing a reoperation for either bowel resection because you have ischemic colitis, you get an infection in there, organ failure, hernias. Never had the compartment syndrome, but if you have a big retroperitoneal hematoma, can definitely cause problems, have to go back in and repair that. EVAR. So here we go. So here's an EVAR. So this is what we do for our aortic aneurysms. abdominal aortic ones. And so there's different types of leaks you can get with these. So these are things that we have to monitor closely. They actually have to be monitored for life for these. First type of endoleak is having a leak here where it's implanted by the renal arteries or at these peripheral sites. That's the actual seal zones. We notice that right away with the angiogram, and we repair those actually before we even complete the procedure. The one that we watch as an outpatient is type 2. This is with the vertebrals and the IMA. Obviously, those vessels are attached to the aneurysm sac, and we are blocking that off. They tend to seal off themselves within a few months, but it's something that we have to watch very closely, because as the sac continues to grow, we'll have to do another like endovascular procedure to put coils in it to block them off. Number 3 is we sometimes have extra limbs here, so there's another seal point that sometimes we have to put a cuff in. Again, we fix that right away. And type 4 is old. It's a porosity issue that we really don't have with the new grafts. All right, I'll just quick go over popliteals. Popliteals are easy. You're either going to open up their knee, either bypass the aneurysm, or you're going to cut it out and put in a straight bypass through there. Good for younger folks, up and moving more, will heal a lot easier, but if you think about cutting the back of your knee, it does take a lot of rehab therapy, and you're at risk of cutting some important nerves and causing neuropathy. Endovascularly, you can go ahead and throw a stent in, because we like to put stents across everything. The only problem really with the stents is stent fracture. This is an area that's very bendable. And so you have to make sure that that stent is a good graft material so it doesn't distort, fracture, or things like that. But we've had some very good luck with those. Another thing for folks to remember is our post follow-up. We follow them very closely at first, but then they'll go back to family practice usually after a year. After a year, the biggest thing is for if they have an endovascular repair, they have to have imaging yearly to make sure that none of those stent grafts move or migrate, because they can. They've had studies out to 5 years to where they've had limbs migrate at that point. So we do have to make sure that anyone who has had that does continue to get yearly follow-up. Open repairs generally every 5 years. After that first year is sufficient as long as there is no complications. Cerebrally, they usually actually don't do any imaging until 6 months, and then they do a cerebral angiogram. So that way, if any of those coils have compacted and there's any growth in the aneurysm, they can repair it right away. So some take-home points. Basically, don't forget your physical exam. That's your most important place to go. Get that good social history background. Control what you can control. Get them off smoking. Get that blood pressure under control. Please contact us, consult us if you don't know. It's neurovascular for cerebrals and vascular HBI for all those truncles. They will be on dual antiplatelet. A lot of people don't like that. I don't care. Keep them on it, please. We'll be the ones to stop that, and then they will generally be on aspirin for life. If they have any problems, please contact our office before just stopping these medications, because it can cause thrombosis and cause further problems for them, which can lead to limb ischemia and things like that, which we really don't care for too much. So, and that's it. Thank you.
Okay, all right. So my name's Jason Neese. I'm a PA with cardiovascular surgery here at Monument Health in the Rapid City campus. So I thought that ECMO, ECLS would be a great topic to talk about because as our institution moves towards the exploration of providing more definitive therapies for advanced heart failure, and as we, as a surgical group, continue to escalate our ability to provide more complex cardiac surgical procedures, the topic of ECMO and ECLS becomes ever more pertinent. ECMO, the concept of extracorporeal membrane oxygenation, has been around since 1950s. And it's really evolved since then. Here we have a picture. This is actually in the subway system of Paris. Since 2011, they have an ECMO team, and for refractory cardiac arrest, they'll deploy their ECMO team and actually do cannulation pre-hospitally. And a lot of centers in America have started to do that. So pretty fascinating subject. So the objectives of this talk is just to understand the basics of the ECMO circuitry. What is the difference between VV and VA ECMO? How does peripheral versus central VA cannulation work? Understand the very basics of ECMO cannulation, review the basics of the physiology and hemodynamic profile behind someone on ECMO, be able to define the indications for VA ECMO, review the CardioHelp machine basics. The CardioHelp is a maquette system that we use here at Monument Health. The metrics and the importance of pulsatile flow, the daily checklist that we go over every day when we have an individual on ECMO, and the complications, as well as the weaning strategy. And so just as a caveat, ECMO, ECLS is a huge topic, and there are day-long, week-long courses devoted to this. So this is kind of hitting the very basics, and there are certainly very many permutations within those basics. So just basically, what is ECMO, ECLS? So ECLS is extracorporeal life support. It refers to the utilization of mechanical devices for temporary, days to month, provision of partial or complete surgical support to the heart or the lungs in the case of cardiopulmonary failure. For this topic, we'll talk mainly about VA ECMO. We certainly will put people on VV ECMO, but for a majority of our ECMO cases is post-cardiotomy shock, so we usually put them on VA ECMO. So ECMO is a circuit, and it involves draining blood through a catheter from the venous system, circulating in a pump, and then reinfuse it either into the venous or arterial system, whether you're on VA or VV ECMO. The circuit itself consists basically of drainage and return cannula. Cannula are just these little guys right here. They're just polyethylene pipes that go in and out of a patient, and then a pump and a heat gas exchange. So, choice of ECMO. Two main types of ECMO are used. There's VA and VV. Sometimes you'll hear it called VB, which is venobifurcation. So for VV support, you're only going to be using it if someone's lungs have tanked. So traditionally, before COVID, we would use it for someone who had, classically you would have like influenza pneumonia, MRSA pneumonia, necrotizing pneumonia. I've seen it used in a lot in pediatrics too, where their lungs just aren't working with meconium aspiration, whatnot. And now, with COVID, kind of like revamped VV ECMO. We're putting on people. My previous institution, we're putting people on VV ECMO all the time for COVID pneumonia. So within VV or VB ECMO, there are two subtypes: single site and dual site ECMO, VV ECMO. Single site is where it involves insertion of a single cannula into a vein. So you can actually insert it. It's called the Avalon catheter. You insert it into the neck vein, and these are people who can get up, they can walk around. It kind of frees them from a lot of the circuitry of a dual stage or a dual site ECMO that involves insertion into two cannulas into different veins. Like in this picture, through the vein in the neck and then a vein in the groin. All right. So VA ECMO, veno-arterial ECMO, provides both respiratory and cardiac support. So this is in a situation where the lungs and the heart really aren't working very well, mainly the heart, since the heart is really kind of supporting the lungs. So you have to support both veno and arterial systems. So within VA ECMO, I kind of have defined two subtypes. There's peripheral VA ECMO and central VA ECMO. And you can see that see if I have anything else. With peripheral ECMO, there will be insertion of cannulas into peripheral veins and arteries. And these are, two of the arteries that we will commonly use, a femoral artery or an axillary artery. And we usually sew a little piece of graft material onto those arteries so we can stick those cannulas into it, not directly into the artery itself, although you can do that. While central VA ECMO involves insertion of cannulas into the heart and great vessels. If someone comes out and they're centrally cannulated, usually this happens post-cardiotomy shock, and they've been centrally cannulated on the heart-lung machine, and so we just keep those cannulas in, and they come out with an open chest. But there are strategies on why you should do central versus peripheral cannulation. When we centrally cannulate someone, we usually like it because it allows for a higher flow state. The machine can basically run blood through the body and the system at a greater capacity. It allows for better drainage. But there are considerable challenges that we have to overcome. There's a significant increased risk of bleeding and infection. And you have to deal with a lot of temperature variations with someone who's centrally cannulated. If they're peripherally cannulated, it offers a reduced bleeding risk. There's possible lack of surgical incision. You can do this via a cylinder technique where you don't necessarily have to cut down to the vessel, so you don't have to necessarily create a surgical incision in order to cannulate them. But there's an issue of limb ischemia because these cannulas, they're huge, and they'll sometimes cause the limbs to become ischemic because you don't have any inflow anymore because you're not able to get blood through the cannulas. For instance, if you insert a cannula into the femoral artery, and there's also low flow states. And then I just had, cannulas are made of plastic tubes that are placed in veins and arteries. On the note that I just kind of went over about the cylinder technique, we can place cannulas through different methods. We can either cut down to the artery, so that actually, make it a surgical incision, you actually visualize the artery and open it up. You can do percutaneous insertion, and this will usually be on pediatrics. We don't do pediatrics here, but in a lot of larger pediatric centers, they'll do percutaneous insertion. You can do a combination of cut-down exposure and cylinder cannulation, which is what we've done before. We've done cut-down, and then we've also done kind of a hybrid combination of that. We being Dr. Mangara and his surgical team. And then you can do direct cannulation. This is kind of a central cannulation strategy. Direct cannulation through the right atrium and the aorta through a thoracotomy. And this is usually done as kind of a routine procedure during an open heart procedure. And if someone crashes on that open heart procedure and we can't get them off the heart-lung bypass machine, we'll just transition over to central cannulation through ECMO. Cut down of the neck vessels is usually necessary for babies and small children, although you can do percutaneous in children over 2, usually in adults. Okay, all right. And then heparin is usually given as an anticoagulant. Someone who's on ECMO is very pro-inflammatory, right? So the blood really and the body products aren't really made to be outside of the body, and so as soon even though a lot of manufacturers will try to make it as hospitable to the body fluids as possible. As soon as blood and the blood products hit something that's outside of the body, you'll have a pro-inflammatory cascade, which can really promote all sorts of things, but clotting is something that we really worry about. And so we'll usually use unfractionated heparin as an anticoagulant in these individuals. We guide our anticoagulation by ACT, which is activated clotting time, and usually we want 180 to 220 for our activated clotting time on someone who is on ECMO utilizing unfractionated heparin. When they're on a heart-lung bypass machine, those ACTs can be anywhere from 400 to 600, so a lot less anticoagulation is needed for someone who is on an ECMO machine outside of the OR. So this is just physiology basics. I really like this graph because it kind of goes over the different types of ECLS. And remember, ECLS is kind of an all-encompassing term to include not only traditional ECMO, but also VADs, which are ventricular assist devices. So a catheter will withdraw blood from a cannula through veins that consist of the blood consists of high carbon dioxide, low oxygen content. So the deoxygenated blood is then extracted from the venous catheter and gets transferred to an oxygenator with the help of a pump. An oxygenator works as an artificial lung, and it maintains CO2 extraction and oxygenation at a certain flow rate. And the blood is then warmed and then returned either to a vein or a artery, depending on what type of ECMO strategy you're utilizing, to be recirculated into the body. And that can either bypass the lungs completely or go through the lungs, depending on the cannulation strategy that you're utilizing. So this is a nice pictorial hemodynamic algorithm that you can use to kind of visualize how we see someone and how we manage someone on ECMO. Managing someone long-term on ECMO is a very time-intensive process, and you have to think of it differently, completely differently than any open heart or any intensive care patient that we're dealing with. So the mean arterial pressure, right, we think of as involving 3 different metrics. So it's the flow, and the flow is consisting not only of the circuit, right, which is the ECMO pump, but also you have to consider the native cardiac output, right? Some of these people will come out and they will have 0 cardiac output. Their heart will not necessarily be pulsatile. They'll be in PEA. And so they'll have non-pulsatile flow, and so they'll rely completely on the ECMO machine. And so eventually we hope that they regain their pulsatility, and so you have to kind of vary the amount of flow that you have on your ECMO machine. So it's flow times SVR, which is your systemic vascular resistant. We can traditionally and classically think of that as our afterload. And the afterload is very sensitive to the pump on the ECMO machine is very sensitive to afterload. So we use certain agents like norepinephrine, or this is sodium nitroprusside, which we don't really use here, or a vasodilator. So, a vasoconstrictor versus a vasodilator to help control our SVR, which can influence our flows. And then, so it's flow times afterload, and then you add in the preload. And the preload, the pump itself is very dependent on preload. So if you don't have enough fluid inside of the body, what can happen based upon the circuitry of the ECMO machine, you can have these suction alarms. So the ECMO machine will actually suck down on the veins or the arteries, whatever respective vessels you're using, and it will cause a suction alarm, so we need to give more fluid to the patient. And sometimes we need to take off fluid of the patient, and so we'll use diuretics, IV diuretics, or if situations are dire, we'll also utilize CRRT. So for VA ECMO, which is a majority of what we do here, our indications are usually cardiogenic shock. We will sometimes electively place people on ECMO for VT ablations. If we think that the heart won't be able to handle a VT ablation, we have done ECMO for that. But traditionally, most of our experience has been placing an individual on ECMO for cardiogenic shock. And this is usually post-cardiotomy cardiogenic shock after open heart surgery. We can't get them off the heart-lung bypass machine, so we have to transition over to ECMO. So this is the system that we use. It's called the Cardio Help System. It's actually just absolutely amazing that they have put all of this into this little box. It's about, yay big. And it is capable of keeping an individual alive for a certain amount of time. It has a battery reserve on it, so you can take it on a plane, you can take it on a helicopter, and so it's very transportable. There's just some basic metrics to go over. There's the flow right there. So that's basically you can think of it as kind of the artificial cardiac output. And remember, the cardiac output in an individual is usually about 6 to 8 liters per minute. And we control the flow by adjusting the RPMs of the machine. And that's a centrifugal pump that's in this machine. And so this little dial right there, as you put up the dial, you can actually put up the RPMs to adjust the flow of the machine. And if we have someone on ECMO daily, we'll do flow checks and turn down the flows and see how the hemodynamics adjust. And we turn down the flows by adjusting the RPMs. The inflow and outflow pressure will tell you the pressures that are happening of the fluid going in as well as out of the patient. And you can tell essentially whether someone's preload is high or low, what we need to do about afterload while looking at the arterial line pressures. And then the SVO2 can help us figure out certain differentials if a patient's hypoxic or hypercarbic, or if they're, we're thinking their cardiac output is very low. It's a mixed venous oxygenation. We'd like to generally keep it at above 60 and then below 80%. And then if it's below 80 or below 60 or above 80, it can mean different things in different clinical situations. And at the very back is the oxygenator. And the oxygenator is kind of the lifeblood of the machine. And we always want to watch this throughout the person's time on ECMO, because sometimes you can see little white clots in it, and those are fibrin strands that are kind of a harbinger of the entire machine clotting off. And as you can think, once that machine's clots off, it's kind of game over for the patient. So, standard cardiac output, I said 6, but 4 to 8 liters per minute. It's important to note that in certain cases, patients have no natural flow and depend entirely on the ECMO machine, whereas in other times, patients will have minimal cardiac flow, so that kind of necessitates a balance between circuit flow and the patient's native flow. Just really briefly, does pulsatile flow matter? It really does, and so they found that loss of pulsatile flow can have really detrimental effects on patients. Multi-organ, because organs really respond well to pulsatile flow. In fact, when someone is on the heart-lung machine intraoperatively, there's actually a setting on the machine that actually allows for pulsatile flow. And that's super important, particularly for the kidneys. And so loss of that flow can really have a detrimental effect on all organ systems. So some consequences other than multi-organ failure of not a non-pulsatile flow is you can get intracardiac thrombus from stagnation of blood flow across the LV and the root. And you can have loss of LV ejection, which causes pump-driven LV distension. So once you don't have flow across the LVOT into the aorta, you can get a LV distension, and LV distension is a really catastrophic outcome of not having forward flow. So you can have impaired coronary perfusion, and then you can have MR with resultant left atrial hypertension, which can lead to massive pulmonary edema, which are just two of the many consequences of LV distension. So we can evaluate pulsatility and correct cardiac output by looking at a variety of different things. Clinically, we can look at neurologic function, renal function, peripheral warmth, skin perfusion, GI function, pulse pressure. As the pulse pressure widens, if they have a real narrow pulse pressure, that usually means that there's lack of pulsatility. As the pulse pressure widens, we start to see an intrinsic ability of the heart's natural rhythm and pulsatility to come back. And these are some of the metrics that we look at when we're looking at a patient in terms of pulsatility and overall ability to withstand the ECMO machine. Seeing a lactate that's normal, Mixed venous oxygenation that's above 60%. All of their enzymes looking good. And commonly we'll look at transthoracic or transesophageal echocardiogram to evaluate the LV as well as the LV function. How can you manage lack or loss of pulsatility? You can control the afterload by bringing it down or sometimes bringing it up. If you have to, you can give them fluid for a preload. Poor contractility you can address with ionotropic agents. You can try to control your arrhythmias, optimize your flows, and then make sure you don't have a mechanical obstruction. If these don't work, these options don't work, then you can increase your anticoagulation or you can do mechanical LV decompression. And so usually we don't face this when someone's centrally cannulated because we usually have what's called an LV vent in place, which helps vent the LV. Alternatively, what you can do is you can put an Impella device in to vent the LV, which will help prevent any type of LV distension. So we've gone over these two metrics. So this is what we look at on a daily basis if someone's on ECMO. We're looking at what the flow rate is. We're looking at the pump speed. We're adjusting, remember, the RPMs to affect our flow rate. We're looking at our pressures to make sure those all look good. Your delta P is basically a transmembrane gradient that can tell you that if it's above 50 millimeters of mercury, it will usually tell you that there's some problem with the oxygenator, and more than likely that means that your oxygenator has clotted. And then I went over the SVO2, your mixed oxygenation, mixed venous gas, which can help you kind of figure out a problem with someone who's on ECMO. The ECMO machine not only acts as a heart, but also acts as a lungs. And remember, the lungs are responsible for oxygenation and also ventilation, which is removal of CO2. And so you do this by, and this being the ventilation oxygenation, by adjusting the sweep rate and the FiO2, which is the inspired oxygen within the machine. And the sweep rate will basically help you control the amount of CO2 that you're running off of a patient. This is our daily ECMO checklist. So this is everything that we go over. We being the APPs, the surgeon, the intensivist, the perfusionists that are on board, as well as the nursing staff. We go over and really do a comprehensive assessment of the patient because, very small issues in an ECMO patient can quickly lead to catastrophic consequences. This is just, I gave this talk as part of an education for our ICU nurses. So we talked a bit at length about kind of a daily checklist that we should adopt in terms of our monitoring of ECMO patients. So this kind of goes into it. And really, it's important, at the end, really that we're owning our ECMO patients and owning the circuit, because if the circuit goes down, the ECMO patient goes down. It's an incredibly time-intensive and resource-intensive process, but we've had some success with our ECMO patients. The mortality and morbidity of these patients is exceedingly high, especially in the context of post-cardiotomy patients. And a lot of them we've sent to University of Minnesota for further care and monitoring. Weaning from ECMO. So there are certain questions that you want to ask, so how to determine when you're ready? Well, you want to know the cause. Why were they on ECMO in the first place? You want to make sure they're on minimal support. And that's really going to be, your support is really going to be institutionally based. So this might be a certain amount of pressors. If they're still neurologically not intact, if they're extubated, or how much vent settings they're on, if they have a pulsatile waveform, you want to make sure that they have adequate unsupported mean arterial pressures that aren't supported by any vasotropic or inotropic agents. You want to make sure that you've resolved all their metabolic issues and that their lung function is intact. So how do you wean? You do weaning trials. This can either be done in the OR, which is traditionally what we do under TEE, transesophageal echocardiogram guidance, or you can do it in the ICU. You usually need about 1 hour of time to effectively wean someone. You need all your support personnel there. So when we're in the OR, we have the cardiac anesthesiologist, we have the cardiac surgeon, as well as all of the auxiliary OR support and the APP. And we're all on board for the weaning procedure. We traditionally use transesophageal echocardiogram because we feel like we would get really good pictures with that versus a TTE, which traditionally don't get very good pictures. We have a weaning protocol that's set up, and that's usually an institutional basis. Usually what you do is you reduce your flows and you watch your echo. These are kind of the metrics that they're looking at in terms of the echo and your hemodynamics. And if everything looks good, then you can decannulate. And this was just a picture that I showed when I was talking about certain complications that can arrive for echo, but I don't think that's really pertinent for this, ECMO, I don't think that's really pertinent for this discussion. So hopefully this gives you a brief understanding, and it's a very complicated topic. I could talk about it for days and weeks. It's so fascinating and so fun to talk about, but hopefully this gives you an understanding into kind of our world, where we're hoping to head, and some of the barriers that we have ahead of us. So thank you very much.
Okay. Thank you, everybody. That was awesome. Do we have questions for
We have
any of the
time.
members, any of the talks?
We have time for just a couple questions. Got one here.
Okay, so for Evelyn, how often are devices interrogated on a regular basis? Do you do it on a regular basis?
There's a schedule that the device clinic adheres to that CMS recommends. So every 3 months or every 6 months, and they also receive remote transmitters. So some of the checks are done from home, the automatic transmissions, every 3 months, and then once a year, once patients are stable, and they go to once a year in clinic checks, just to recheck thresholds and settings. But if the downloads, the remote transmissions come through and there's anything wrong, then we'll bring them in sooner.
All right, we'll give her option 2 for question unless somebody else has one. Looks like you're going to have your option 2 here.
Okay, Jess, so what is the prevalence for a man 65 or over that has smoked for 40 plus years to have a AAA?
What is the chance of him having one?
Mm-hmm.
Probably about 80%.
Okay.
Who else has a question? She's got one more. Do you have one over there, John?
I'm kidding. I'm forcing people to have questions
All
over
right,
here.
we'll just go with one more here.
And for Jason, what is the survival rate for somebody that's on ECMO?
Oh, that's really hard. You know, so post-cardiotomy, it's usually about a 50% mortality coming out of the OR. So that's the only statistic that I know. You know, if someone's on VV ECMO, so I worked at a center where we did a lot of VV ECMO, and the survival rate was really outstanding. Particularly, if you're looking at ECMO in pediatric populations, the survival rate is, for VV ECMO, it's usually much better. For VA ECMO, across the board, it's usually going to be less, because that means that you usually have, you know, the hearts that's failing, not just the lungs.
I'm trying to remember the COVID numbers. I think when people were on vents and failing, I think it was only 18% survival, and it might have doubled with ECMO in the COVID people, but still wasn't good.
Yeah.
All right. Thank you, guys.
All right, I think we're going to forego our break because of